Okay, hello, welcome everybody to this presentation. Today we will talk about the musculoskeletal system. So we start our lecture refreshing the anatomy of the bone. So remember the bone is divided in epiphysis, metaphysis, and diaphysis. Okay, we have also the bone cortex and the marrow matrix. There are different studies we can perform in this musculoskeletal system. We have plain X-rays, ultrasound. We have also CT scan, MRI as usual, and also imaging guided in interventional procedures. Okay, so we can do biopsy and drain fluid as you know very well. Okay, so let's go and entrance the contents of our lecture. First, we will talk about fracture, sprain, dislocation. Then we'll talk about tumors, bone infections. We'll talk about of back pain as well. So this is a very interesting lecture where you be leading with this kind of diseases the rest of your life as a doctor. So let's go and talk very fast about fracture. So fracture is a break in bone or cartilage, and usually a result of trauma. Also can be result of an acquired disease, such as osteoporosis. Also, we have a sprain. The sprain is a joint injury in which some of the fibers of a supporting ligament are ruptured, but the continuity of the ligament remains intact. It's very important you have to highlight this one. The continuity of the ligament remains intact. Now we have also dislocation. So dislocation is a complete separation of two articulating bony surfaces, often caused by a sudden impact to the joint. So a partial or incomplete dislocation is called a subluxation. Also, any joint may become dislocated, common size as shoulder, finger, patella, and elbow. So, like I say, in dislocation, the ligament doesn't remain intact. Okay, the ligament doesn't remain intact. Sprain, the ligament remain intact, but not in the dislocation. Dislocation, the ligament doesn't remain intact. So let's go for the example of dislocation. So you can see this dislocated shoulder. Okay, is very common, like I said before, and it's very painful. So you can see in the dislocation we are going to have this soft tissue swelling and this severe pain, severe pain. So before you send the patient to X-ray, you have to reduce you have to reduce the dislocated joint because it's really painful. So this technique you go to learn, I think, your fifth year on the orthopedic rotation. So, but what is important I want to talk is the difference between sprain and dislocation. So, what happened in the sprain? There also a soft tissue swelling, but the pain is not that severe. The pain is not that severe. The ankle is one of the common joints can get a sprain because of the work of the people. In elderly people, also in young people can occur that one. And the other issue is there is no joint deformity in the sprain. There is not joint deformity in the sprain, but there is joint deformity in the dislocation. That's the main difference between a sprain and dislocation, right? That the main point. You have to put that one in your head. So these are examples of different type of dislocation. You can see the shoulder, knee, and the hip. Okay, and the hip. So let's move on. Let's go to pass and talk about fractures. So to see, remember, fracture is a break of bone or cartilage. So we have a sample of fracture. This is another example of fracture, the skull fracture. You can see it's marked with the arrow. is marked with the arrow. This is the example you write the CT scan from the same patient. This is the breast fracture of the skull, which is very, very common. This is another example of fracture. Sometimes the fracture is very difficult to see. There are no, as this one, which is this one, is very easy to diagnose, okay? But there also we have others which is very, very difficult to see. You can see in your left this lucent line in the skull, okay? This is a sign of a fracture. You can see it's pointing by the arrowhead. And this is CT scan, so we compare there is a base skull fracture, which is very, very dangerous, okay? But it's not quite visible. But the sign of symptom of the patient can help you on that. Another type of fracture we have left form. So this form there for maxillofacial especially. Okay, so you can see we have a different type of fracture. We have left for 1, left for 2, and left for 3. In left for 3, the face is separated from the skull base. It's something really, I think, horrible to watch. I saw once before, one was very, very difficult, but you have to know this kind of fracture as well, okay? Yeah, for your general knowledge. Now, let's go to talk about the classification of the fracture. There are multiple classifications of the fracture. I think there are more than 100, okay? But they are similar. They are very similar each other, okay? Basically, the fracture can be divided in green stick, spiral, comminuted, transverse, or compound. Also, you have a better vertebral compression or vertebral fracture. This is a sample of another of the another classification. We have open fracture, closed fracture, incomplete, complete, displaced, and comminute fracture. Remember, you have to go pause the video, go and look for a sample of the kind of fracture, okay, just to increase your knowledge. Remember this type of presentation is sort of for orientation, so you have to go and do a research about what we are talking about, okay? Remember, you are a medical doctor, you have to be very curious, and you have to read the bottom of your knowledge always, okay? So just pause the video, look at the samples, Google, see some pictures, and you can go deep in your knowledge. So these are a sample of open fracture, okay? This is a displaced and open fracture. You can see the fibula just broke the skin, okay? It's a terrible situation. Now, after the fracture, we have a healing process. Always after the fracture, we have a healing process. So what happened in the healing process? In the healing process, we have four phase or 4 stage. We have the inflammation stage, soft callus, hard callus, and remodeling. I'll repeat again: inflammation, soft callus, hard callus, and remodeling. So this is a sample. This is a baby fracture in which we have the first day. The day number 1 is just occurred the fracture. 3 days later, we start with the inflammation. You can see there is a mild opacity surrounding the fracture. Then day 7 we have the soft callus. 2 weeks later we have the hard callus, and 6 months we have the remodeling. You see the bones just become as a normal. It's like never this bone had a fracture. But remember, this is children. So in children, these process are very fast, and the remodeling phase is very, very, very good. Not at the adult. Okay, so adult, when you have a fracture, you delay up to 2 years to the full remodeling process. Also the pain of the sometimes the patient if that patient come to the hospital and was assisted by an orthopedic surgeon, okay, because sometimes the patient will stay in the house or just come to the hospital once and they They don't want to come to the hospital again, so there is no follow up. So there is so many complications with this fracture. It's very difficult. Remember, in adult, delay up to 2 years. So this is a sample of another fracture in teen age. This is a teen age patient. So you can see also the both process of callo, heart callo, and remodeling process. Okay, so it's very important to know. Remember, in children, uh, this kind of pathology, the result is better, but in adult, you have to follow up with orthopedic always. So now we are talking, we start talking about cervical spine, yeah, the clinical or radiological evaluation of the patient, okay, with the cervical spine injury. So just let's put this very clear. All patients with documented or suspected trauma above the level of the clavicle should be considered to have a cervical spine injury until proven otherwise. These patients should have cervical spine immobilization until cleared both radiologically and clinically, uh, and to clear both radiologically and clinically. So what happens sometimes then when you have we receive this patient with an accident, maybe a road traffic accident or any kind of accident at the level of cervical spine with damage at this level. Uh, it's very difficult to take the X-ray. It's very difficult for the characteristic of the patient or for the position of the patient. So sometimes the X-ray will come in with the good quality, and sometimes with the all the requirement for the technical of the cervical spine. So this, yeah, I brought this example in your left. You can see this cervical spine, which looks very fine. You can count it. There is a 1, 2, 3, 4, 5, 6 cervical vertebral bodies. But in your left, you can see there is a fracture. Okay, between 6, 6, 6, 7, which is not visible in the first X-ray because the X-ray was nowhere done. So we have this patient with this symptomatology. The X-ray is common, is look at negative, but we can't, and we see there is only 6 cervical vertebral bodies. So we send the patient back, and then we repeat the X-ray, and we find out there is a fracture between 6, 6, 6, 7. That's the important how important to take a proper cervical X-ray, and how you have to know the quality about also cervical X-ray. So the cervical X-ray to have a good quality, you have to see from C1 to T1, from C1 to T1. Okay, so in that case you avoid any misunderstanding or misdiagnosis of the patient from C1 to T1. It's very important to know that. Then this is a sample of another fracture. You can see in your left, and in your right you go to see how to assess the cervical spine. So to assess the cervical spine, you have to try to draft three lines. Three lines: the anterior vertebral line, the posterior vertebral line, and the spinolaminar lines. If you draw all with this line, you're never going to miss a fracture. Okay, it's very important for you to know that. Never go to miss a fracture or any dislocation. It's very important for you to know that. Remember, there's the extension of the cervical spine in the lateral cervical X-ray from C1 to T1. So now another important pathology is back pain. So you know back pain is really frequent here in Ghana because people start to carry the things on the head from the young age. Everything is on the head, so that produces back pain in early stage. So when the patient arrive to after 50, 60 years, the the pain can be severe, and the genetic changes are also severe. So yes, the genetic changes usually appear after 60, but in this case sometimes after 40 appear. because of the culture in Ghana. So you can see the difference between this lumbosacral X-ray, which is normal, but compared with this one. Okay, this is a young patient. This is an old patient. So you can see there is a lot of difference here. In this case, we have advanced degenerative changes with osteophyte formation, disc space narrowing, and end-plate sclerosis. So you have to know that very well. Also, you have to check what is spondylosis and spondylolisthesis and retrolisthesis. Tiene spondylosis, spondylolisthesis, and retrolisthesis. You can see spondylosis is the movement from home to the better body. You have to take the reference the down vertebra. Okay, so you have to check that one. Go check what is spondylosis and what is spondylolisthesis and retrolisthesis. It's very important for you to know that. You have to review that. So pause the video or Google and come back again and continue watching the video so you can get better understanding what we are talking about. So this is another sample. Yeah, this is a CT scan. So you can see all the this space reduced, the genetic changes of the lumbosacral spine. Okay, that's more fluorescence in this case. Okay, remember, pause the video, do more research, and come back to the video. So now let's go to talk about another very important disease. Very important disease which is producing a lot of damage here in Africa. Okay, in this case, POTS disease, or tuberculosis of the spine, which is the most common site of bone infection in tuberculosis. Also, hips and knees are also they are often affected with this kind of pathology. But POTS disease is going to affect, in the majority of the cases, the lower thoracic and upper lumbar vertebra bodies. Lower thoracic and upper lumbar vertebra bodies. It's very important to know. So any patient I think teenage, from teenage above, because I saw this kind of disease in a patient with 13 14 years old, okay, here in Ghana. Also can appear early, but because of the nature of this kind of disease, between 12 some patients start to get this pain in the back. So you have to suspect 12 or 13, a teenage patient, even there's carry things on the market. With this kind of pain, always you have to rule out first POTS disease, tuberculosis of the spine. Always put that on your mind. It's very important. Okay, so we are doctors, so we have to take care of the health of the patient. So the patient, we have to take care of the quality of the life of the patient. It's very important for you. So this is very frequent disease here in Ghana. So you have to pay attention to this one. Okay. So these are samples of TB. You see there is a total destruction of the vertebral bodies. Total destruction of the vertebral bodies. Okay, you can is marked with the arrows. Total destruction of the vertebral body, also fusion of the vertebral bodies. Okay. Then in your right you have a paravertebral tissue abscess. Paravertebral tissue abscess. Sometimes that's another form the period of this kind of disease. So they appear sometimes first with the abscess, okay, in the paravertebral tissue. So if you have any patient with this swelling in the back and this redness in the back, so you have to suspect there is an abscess, and maybe it's possible due by tuberculosis disease of the spine. Okay, it's very important to know. Now, the main diagnosis for this kind of disease, the MRI. Okay, MRI is the one can give you all the information in case of the spine. But with the X-rays and also sometimes the CT scan, we can do also a diagnosis. But the main diagnosis tool is MRI. Okay, it's very important for you to know that. Now let's go to talk about another infection of the bones, osteomyelitis. Osteomyelitis. So osteomyelitis can affect any any bones in the body, any bones in the body. Okay. So what happens with osteomyelitis? The initial plain films are often normal. Are often normal. That is key. So in the early stage, you look for distortion of fat planes and signifying soft tissue swelling or adjacent fluid accumulation. Loosening may be visible after 5 to 7 days. Okay, after approximately 2 weeks, bony necrosis and periostal reaction become evident. So, what happened with this one? There is this boy which is coming to you with this pain in the this upper part of the right lower limb. So this coming with this just pain. That's all. So the physical examination is negative. You request for also for the X-ray, and you're thinking maybe it's a fracture or maybe it's a sprain, and and also the X-ray is negative. Also, is the X-ray is negative, so you cannot send the patient back to the house and say everything is negative, everything is normal. You always have to think maybe there is something coming on there. Maybe it's this kind of infection. Maybe you have to think always infection, always think osteomyelitis, like a pop disease, always think osteomyelitis. So you just follow all the patients, okay? Even the patient that doesn't have fever, follow all the patients. So because the initial plain films are normal, and also there is no distortion of the fat planes, if you have any doubt, you can send in for report that X-ray. Okay, it's also another a way to help yourself and the patient. You have any doubt, just send for comment to the X-ray department. So you just follow all the patients. So in this situation, you have doubt this stomatitis or not, follow all the patient. Just I think give some antibiotic to the patient until the patient will come in 10 days or 2 weeks later. Okay, 10 days or 2 weeks later, and repeat the X-ray. Repeat the X-ray. At this stage, it should be some signs, radiological signs of osteomyelitis. Osteomyelitis, but because you have covered the patient with antibiotic first, the damage in the bones should be less, or maybe none. Okay, that's very important to know. You always have to think of osteomyelitis and act quickly with the patient. Okay, so these are examples with X-ray. You see the first is almost normal. The second one X-ray you can see with the arrow is a lucency, that means there is necrosis. Okay, and you see with the blue line the periostal reaction. You can see there is some tissue density around the bones. So it's bilateral, but in this size it's more prominent. And the other is the MRI. So let's go to talk about now tumors, benign and malignant tumor. So these are the clinical features of the tumor. There are more clinical features where you have to know when you arrive to your, I think, 5 years, your 5th year in your career. But in this case, we are talking about X-rays. So let's go be focusing on X-rays. So about the radiological features of the bones tumors, we have key questions you have to ask yourself. You have to ask yourself always these 7 questions. The relation is solitary or multiple. What is the lesion in the bone? The lesion have well-defined margins. There is a cortical destruction. There is bony reaction. There is central calcification, and also look at the soft tissues. Okay, so I'm going to let these 7 questions to you, so you have to research about this one. Okay, now you always have to think. There is sometimes there is very difficult to diagnose make the difference between malignancy and between benign and malignant. Okay, so always have to refer to the images like likely malignant or likely benign, because we never have the full diagnosis until we get the biopsy of the bones. Okay, until we get the biopsy of the bones. Okay, but we have another study that can help you. Maybe CT scan, we can identify say bony architecture, and MRI. Okay, we can give you invaluables of tissue and bony information, particularly the tumor extent. Okay, and for the final diagnosis, like I said, it's a bones biopsy. But the happen is a bone biopsy delayed minimum 3 weeks for the result. Minimum 3 weeks for the result. Okay, so it's a long time. So you have to act quickly. Is the lesion is benign, malignant is likely to be malignant. You have to act quickly in this regard. So these are examples of the differences between benign and malignant tumors. Okay, so spray. Remember, you have to make a relation of the question before with this answer we have here, so you can get a general idea. Okay, what we are talking about. But you have to ask first that main 7 questions. Okay, so these are examples of benign bone tumor, aneurysmal bone cyst. This is a well defined. This is a thing expanding to the head of the fibula. Okay, this is another example of benign tumor. In this case, is an osteoma in the sinus. Okay, this is another example of benign tumor. Remember, you have to pause the video, go out and get the information, and come back. Okay, this is another kind of the tumor, but this guy is a malignant tumor. We're talking about osteosarcoma. Osteosarcoma. Okay, so you have to research this one, osteosarcoma. What we're talking about is what you have here, all this you see is a sign of destruction, sclerosis, and lucency, and periostal reaction. Okay, that talking about osteosarcoma. This is another sample. This is an sarcoma, which is very aggressive tumor. It appears mainly in the teen age. The teen age is very aggressive. And generally the patient died after 6 months of the diagnosis of the tumor. This is another example of tumor, the metastasis. I'm talking about metastasis. Here you can see this is a forearm. You can see something like a mace in that bone stage. It's eating the bone, the metastasis. And this in the opaque area you see in the vertebral body is also metastasis possible from prostate cancer. Okay, prostate cancer or renal cancer. And then at last, you remember the last conference we talked about multiple myeloma. You can see what the multiple myeloma can do to the body. This pepper spot sign or raindrop sign in the skull. Okay, remember multiple myeloma. And this and you write the 3D reconstruction on the CT scan. You see it's eating the bone. It's very difficult to see. Okay, so you have to always pay attention what is explained to you.